These nice backgrounds. Some familiar faces. Well, welcome back, everyone, to 3D Echo Clinic. I'm Dr. Bob Seiss, addiction psychiatrist with Frontier Psychiatry. We're very grateful for the support from Mountain Pacific Quality Health. We'd like to start off with a round of introductions from the virtual hub. Amber, if you'd like to take the lead.
See, and I wasn't even super quick with my mute button, even though I knew it was coming. So be familiar with your mute button and where that is. So hi, everyone. I'm from Mountain Pacific and work in Montana.
Sharon, would you introduce yourself?
Yes, thank you. My name is Sharon Phelps. I also work for Mountain Pacific and currently reside in Colorado.
Mary?
Hi, I'm Mary Argonis. I will be your project support, IT support for today's Echo. And I'm from Hawaii.
Jessica?
Hi, I'm Jessica, and I'm up in Anchorage, and I'm with Mountain Pacific.
Thank you all so very much. I'm not seeing anyone else from our virtual hub. Amber, I'm counting on you to keep me honest. Let's go ahead with introductions from people who are joining us from the community. And going in the order appearing on my screen, Megan, would you please take it away? Megan Lehman.
Hi, I'm Megan Lehman, and I am a nurse practitioner at Frontier Recovery in Billings, Montana.
Welcome, Megan. Reza.
I'll talk over Bob because the microphone I don't think will echo. I'm Reza. I am a neuropsychiatrist working with Frontier Psychiatry, specializing in dementia care.
Brandy.
Hi, I'm Brandy Colvin. I'm a family nurse practitioner in Bozeman, and I work at Providence Mental Health right now.
Excellent, welcome. And we see someone's joined you, Larissa.
Yeah,
Yes.
Larissa Hammond.
Good to see you, Larissa. Good to see you again.
Nice to see you too.
And I'm seeing yet more familiar faces. Looks like Sarah and Kelly.
Hi, Sarah Porter-Rosen, Director of Operations with Frontier Psychiatry.
Kelly Hyder, Scheduling Coordinator for Frontier Psychiatry. Hello.
Excellent. Dawn. Dawn, it looks like you're on mute.
She just told us to get familiar with the mute button, right? So my name is Dawn Marie. I work with the Wyoming Long-Term Care Ombudsman Program, and I'm based in Riverton, Wyoming.
Excellent. Welcome. Maggie.
Hi, everybody. This is Maggie Oki. I'm with Mountain Pacific team, and I'm in the state of Hawaii right now.
Thanks for joining us from afar.
Oh, we're so excited. Thank you.
Hope.
Hi, I am Hope Kratz. I am the clinical director at Monida, and we are working towards clinical integration, just coordinating all of us for quality outcomes. So it's a great place to be. Thank you for having me.
Thanks for joining us. Maynette.
Hi, I'm Maynette, and I'm also from the Hawaii office and work for Mountain Pacific.
Great, welcome. I see a few other people who are muted with their cameras off. If they could please, at least audio unmute. Excellent. And I see Alona has joined us, also part of the virtual hub. Alona, if you please introduce yourself.
Alona Jarman, I am also with Mountain Pacific.
Excellent. And it looks like C. Allison.
I'm Charlie. I am with Rosewood Healthcare Center in Forsyth, Montana. I work as a patient care coordinator and discharge planner for the hospital.
Wonderful. Thanks for joining. Tara.
Hi, I am Tara Wells. I am in Helena, Montana, and I just opened a practice called Wells Wellness, and I am a medication assisted certified, and I've been doing it for about 3 years now.
Welcome. Caitlin.
Hi, everyone. Caitlin Conway. I'm with Mountain Pacific Quality Health. I live in northern Montana.
Welcome. Mark.
Hello, everybody. I'm Mark Marabella with Mountain Pacific, and I'm also from Hawaii.
Excellent. Jenna.
Hi, I'm Jenna Delisle, Social Services Director at Mission Point Hancock in Michigan.
Welcome. Connected from Michigan. All right. And I see a familiar face, Jessica Lauer.
Hi, I'm Jessica, and I'm the Operations Manager at Frontier.
Thanks for joining. Also see Andrea McDonald. I don't see Andrea. Is it?
Sorry, I don't have a computer video.
Oh, no worries. Hi, Andy.
Hi.
Joining us.
Thank you. I'm a nurse practitioner at Billings Clinic here in Billings, Montana.
Awesome. Welcome.
Thank you.
A few other folks, and someone call out if I'm repeating any names. I don't think so. Sharon Pillsbury.
Sharon Pillsbury joined us in chat as she does not have a microphone.
Okay.
She is a nurse navigator in Lakeside, Montana.
All right. Welcome, Sharon. And Sandy.
Hi, I'm Sandy Crawford. I'm an administrator and director of nursing in a long-term care facility.
Excellent. Welcome. Tony.
Sorry, I'm having some issues with my webcam. Social Services in Gillette, Wyoming. I also have Julie Mason in here with me. She's also in Social Services.
Excellent. And then I think also Julie Cooper is someone we haven't yet heard from.
Julie also joined us in chat because
okay. Excellent.
She works at St. John's Living Center.
All right. And we have a few more introductions. See Jennifer.
Yeah, hi, my name is Jennifer Quinn. I am a nurse complex care navigator for Kalispell Regional Medical Center in Kalispell.
Excellent. Welcome. Roberta.
Hello, I'm Roberta Rosenberger. I am the Regional Clinical Nurse Consultant for Mission Point in the Upper Peninsula of Michigan. So Jenna, who introduced herself earlier, we work together at the Hancock building.
Excellent. Welcome. Is there anyone I missed?
I'm with Clarissa Juarez too. She's a nurse practitioner at Billings Clinic.
Hi, Clarissa.
Hello.
You can join.
Good.
Dr. Seiss,
Dr. Howard Lamley.
I don't think you called out. Howard, Anna, and Agnes are the three that I see.
Okay, wonderful. If we could hear from each of them. I think Howard's right now unmuted.
Yep. Yeah, Dr. Howard Lamley. I'm the program supervisor, clinical director for Three Rivers Mental Health in Missoula, Montana.
Excellent. Welcome.
Thank you.
Hi, good morning, good afternoon. My name is Agnes White. I'm with Mountain Pacific at the Guam office, and I'm a registered nurse. And it's
excellent, Agnes. And good morning to you.
Okay, thank you. 7 a.m. here.
All right, way to start off the day.
Okay, thank you.
And it sounds like there's at least one more person we get to hear from.
Zuby is on.
Guys, I'm listening in the background. Don't want to create an echo. Eric Arzubi here from Frontier Psychiatry. Hi, guys.
3D. All right, and I think we have quorum. So let's jump into our discussion on SBIRT. And Amber is not going to be shy. If the videos are muted, she will certainly let me know. Is the title slide shown well? Fully zoomed? Excellent. Well, hey, thanks so much for joining us today. We're going to be talking about screening, brief intervention, and referral to treatment, SBIRT, why it's compelling and why we really need to leverage this tool to better engage our patients and meet them where they're at in their need for substance use disorder treatment and help them along the way to recovery. Brief disclosures, I'm one of the owners and co-founders of Frontier Psychiatry. It's a Montana-based, fully virtual psychiatric practice. I will not sell our services in this forum. And Amber, along with others, will make sure this does not happen. On continuing nursing education, if you attend this entire session, you are eligible for 1 credit hour. You do need to attend the full hour, and you will receive that credit at the end of the series. Please stay tuned for updates on continuing medical education. So on to SBIRT. Our objectives today are to review the epidemiology and treatments for substance use disorders, summarize the SBIRT process and its evidence for effectiveness, discuss and address potential barriers for incorporating SBIRT in practice, and discuss referral to addiction treatment services. Last week we touched on this. Substance use disorders are remarkably prevalent among us as adults here in the United States. Over 20 million of us will meet diagnostic criteria for a substance use disorder in any given year. That's roughly 6% of the population, with 16 million American adults meeting diagnostic criteria for alcohol use disorder, and some overlap with just over 6 million meeting diagnostic criteria for an illicit drug use disorder. Yet only 7.5% of those with these substance use disorders get treatment. When it comes to opioid misuse and abuse, 1/4 of patients who are prescribed opioids for chronic pain end up misusing them. 10% go on to develop opioid use disorder, and 5% who misuse prescription opioids ultimately transition to heroin, making prescription opioid misuse the gateway to heroin. If we look at the interval of, if I could ask that everyone mute, I'm getting some background noise. It may be, okay, oh, it's still there. Amber, it might be you, I'm not sure. So if we look at the interval from 99 through 2017, we see across the United States a 3-fold increase in opioid overdose deaths. In Montana, which tends to be representative for the region, Montana, Wyoming, and at least parts of Idaho, as well as the Dakotas, over that same interval, we only saw a 2-fold increase in opioid overdose deaths. Seemingly reassuring, yet we know, based on the latest DEA seizure data, opioids are more prevalent here in Montana, and if anything, we're catching up to the rest of the nation. If we look at teenagers, we see very concerning trends, specifically from 8th grade up until senior year of high school, huge increases in current drug use, going from 5% of all 8th graders to nearly 1/4 of high school seniors. And remarkably, over 10% of US alcohol consumption comes from teenagers, underage drinkers. So how do we engage with our patients about their substance use? As a child of the early 80s, I couldn't help but think back to the message I saw on the TV as a kid that I think is pertinent for pretty much everyone attending this discussion, unless you're super young.
And to make it count. Say yes to your life. And when it comes to drugs and alcohol, just say no.
So we should be one and done, right? We can just say no, as Nancy Reagan taught us, and be done with it, right? We can just tell our patients not to use alcohol, or at least cut back to moderation, and don't touch illicit substances. Done. This discussion's over. Thanks for attending. You know, if only it were that simple. We're constantly challenged with how to best engage patients about their substance use. Do we take a maternalistic or paternalistic approach and tell them, don't do that, this is going to kill you, or at least make your life a lot worse? Do we recklessly engage with them through an empathetic stance in which we say, hey, understand, this drug use is a big part of your life and I can see the reasons why you're doing it? Or do we kind of passively cite all the evidence that supports abstinence, or at least drastically cutting back use? What if there were an evidence-based process for identifying at-risk substance abuse and engaging with our patients? Well, sure enough, SBIRT is just that. When it comes to brief intervention, let's see this example.
And meth is it's just a part of it, I mean, everybody's doing it there, so while I would like to stop, it's kind of hard to think about doing that right away.
So you recognize that methamphetamine has some problems associated with it. And you also, on the balance, see that a lot of your social life and your sex life involves methamphetamine. It would be difficult to quit using.
Yeah, I don't think it would be easy, but I'm not saying I'm not willing to try.
Well, if you were to consider how ready you are to stop using methamphetamine completely, with 0 being not ready at all, and 10 being very ready, where would you put yourself?
3.
Why not a 1 or a 2?
I mean, this has been really uncomfortable, this gonorrhea is like really bad experience. And I know I don't think the same, when I'm on it. And I mean, what I have is bad enough. I could easily get AIDS. I could get HIV the same way. So that scares me a lot. That's why it's higher than a 1 or a 2.
Are there any other concerns that you have about methamphetamine?
Well, I do just snort it, but you don't always know what it's cut with, and so there could be something, it could be really bad if it was cut with something dangerous or something. I mean, I worry about that sometimes.
So when I was first talking to you, I thought that you would have very, really not much interest in stopping using methamphetamine, but it sounds like you have a number of reasons why you really would like to stop using methamphetamine, and that is that it might be cut with something else. You could get another STD, including HIV.
Yeah.
What do you think would make it easier for you to cut down or quit using methamphetamine?
No, if that
So we saw a radically different approach that really sought to elicit a narrative from the patient that acknowledges his ambivalence about his methamphetamine use, the good and the bad, and really tried to elicit an inner reason or an explanation coming from the patient as to what he would like to do when it comes to his meth use. Insofar as finding a way to give a summarizing statement, and the gem I hope that people leave this discussion with is SBIRT gives us a way to meet patients where they're at, insofar as identifying those who are in need of substance use disorder treatment and help them meet their unmet needs for treatment and change. The rationale for the approach of SBIRT comes from the epidemiology of alcohol abuse here in the United States. Specifically, we see that a pyramid model of the distribution of alcohol use, going from the base of low risk or abstaining from alcohol to hazardous at-risk use, all the way to alcohol use disorder, is a nice way to think about the different levels of use and correspondingly the different levels of need for intervention, and in some cases treatment. Just over 2/3 of US adults either abstain or drink alcohol entirely within the limits of moderation, whereas about 1/4 are engaged in at-risk use. While they might not have physiological dependence on alcohol or some of the functional impairment we look for in diagnosing alcohol use disorder, the amount that they're drinking and the sort of things they're engaged in really put them at risk to reach that top of the pyramid, the 4% of American adults who have alcohol use disorder. SAMHSA, the Substance Abuse and Mental Health Services Administration, which is part of the U.S. Department of Health and Human Services, leading public health efforts, specifically targeting general mental health concerns, and within that, substance abuse. SAMHSA advances SBIRT as a public health approach, allowing us to identify patients in need and guiding us through early interventions for patients with risky alcohol and drug use. And it helps those patients get timely referrals to more intensive substance abuse treatment. The approach that SAMHSA describes that an SBIRT model must have includes universal screening, so all patients, 5 to 10 minute long brief interventions for those patients who score high enough on that screening to merit the brief intervention, that one or more specific behaviors related to risky alcohol and drug use are targeted, that the services occur in a public health non-substance abuse treatment setting, and that it includes brief intervention and referral to treatment. Definitely want to emphasize that the services, insofar as the brief intervention in particular, and in some cases, some of the treatment, specifically the psychosocial component, that's to take place in, for example, primary care. It is not a model that favors those services being offered in specialty addiction treatment centers. If we look to the evidence for the different components of SBIRT, we see that sure enough, given SBIRT was constructed, take into account the epidemiology of alcohol use disorder, sure enough, the screening, brief intervention, brief treatment, and referral to treatments components of SBIRT all have relatively strong levels of evidence supporting their use. Interestingly, when it comes to using SBIRT to identify people who are abusing illicit drugs and then connect them with brief intervention, brief treatment, and a referral to treatment, surprisingly, the evidence isn't as strong when it comes to brief intervention, brief treatment components of SBIRT. Definitely strong, statistically significant findings supporting the use of screening tools for substance abuse, but the brief intervention, brief treatment aren't as supported, whereas referral to treatment, in fact, is supported. Tobacco use, it turns out, has a similar level of support across all components of SBIRT to what we see for alcohol abuse. And part of this difference in the level of evidence for SBIRT in screening for substance abuse versus screening for alcohol use has to do with the fact that the screening tools for substance abuse were specifically developed and validated in specialty care settings, like addiction treatment centers. So the tools themselves come from a different mechanism and process, very distinct from what we saw of audit and cage screeners used to screen for alcohol use disorder. The SBIRT process starts with screening. It then seeks to risk stratify patients based on their level of alcohol or illicit substance abuse, falling into low risk, moderate to high risk, or outright alcohol or other substance use disorder. And after that risk stratification, we can then pursue the indicated level of care. In many cases, for low risk folks, no further actions taken, perhaps psychoeducation, allowing them to review what are the cutoffs for moderate levels of alcohol intake. For moderate risk folks, the brief intervention that we saw modeled just a moment ago, moderate to high risk, we're seeing brief treatment as the highest efficacy. We'll talk about that more in detail in just a moment. And then finally, for those who actually have the alcohol or substance use disorder, they need specialty treatment. For screening, there are a variety of tools available. Those targeting alcohol use disorder that have the most robust evidence supporting their use include audit, cage, and for children, CRAFT, especially the new second version. For illicit substance abuse, DAST is by far and away the most robust screening tool. If we look to audit, kind of the easiest way to think about this, it has given us a way to quantify how someone is using alcohol based on the DSM-5 criteria for alcohol use disorder, also with a specific focus on the amount of alcohol consumed. Definitely want to highlight what we're talking about when it comes to the different amounts of alcohol that patients will commonly refer to. This specific screener, you have to keep in mind, it refers to a standardized beer, which is 12 ounces of 5% alcohol concentration beer, a 5-ounce glass of wine, and a 1.5 ounce shot of liquor in a cocktail or alone. Oftentimes patients are referring to a drink that is very different than what we see depicted here. In short, on average, here in the US, when people say drink, they're oftentimes referring to more alcohol than would be captured if they just go by the amount that they consume. So this screener, it asks how frequently people drink alcohol, and specifically then looks into how many drinks are consumed on a typical occasion and how often people are engaging in at risk, perhaps binge drinking, specifically how many times are they drinking 4 more drinks on a given occasion in a week. And then the following questions really focus on the functional impairment we see with alcohol use disorder, insofar as risking physical injury, having very, very trusted, important people in the patient's life instruct them to cut back, feeling guilty about alcohol use, and other forms of functional impairment. We can then take the score from audit to risk stratify. Slightly different cutoffs for women versus men, and this is a function of the fact that on average, women do have lower body mass, so it takes less alcohol to cause impairment. Additionally, men are slightly faster alcohol metabolizers, even correcting for weight. So a score of 3 or lower for women, 4 or lower for men is low risk. If we then look just above that, up to 12 or up to 14 for men, that's risky, and that prompts the brief intervention. 13 through 19 for women, 15 and 19 for men is considered harmful drinking. And here we're looking to really leverage services, and we're even considering going a step beyond the brief intervention, the psychosocial treatment, to look to refer to specialized treatment. Lastly, for scores of 20 and above for both men and women, that prompts a lot of concern for outright alcohol use disorder, really urging us to get the patient to specialty treatment. The evidence for audit is quite robust. It has very good sensitivity, over 90%, and the specificity is also very high, 80%. A score of greater than 20 strongly suggests alcohol use disorder. Audit has been validated in primary care settings, and a VA study discerned that using electronic clinical reminders following screening with an abbreviated form of audit helped people stay within moderate drinking ranges. The abbreviated form of audit is certainly one way to make this screener more accessible to people, in particular keeping in mind we're doing a lot of this in the primary care setting. The abbreviated version consists of just the first 3 questions, really looking at the quantity and frequency of alcohol intake. And you can see that the sensitivity is generally preserved across the board for both men and women. It's still around 80 to 90%, lower specificity, but it's still meaningful. And sure enough, if they screen positive on this, it's not going to be iatrogenic or at all detrimental to ask a few more questions that would allow us to essentially screen out the false positives. The DAST is the main screener we have available for screening for substance use disorders. You'll note it in a fairly comprehensive way asks about different substances of abuse, from meth to tranquilizers, cocaine, hallucinogens, cannabis, opioids, and it asks about how often people are using. And in a dichotomous way, it wants to know, is there any misuse of drugs, using, for example, prescription opioids other than for medical reasons. No or yes to all of these. And lastly, it also asks about whether or not people inject drugs, if they've ever received treatments. And I should mention, there's a focus very similar to audit on whether or not people are experiencing any sort of functional impairment. Again, part of the core diagnostic criteria for substance use disorders in the DSM. The interpretation similarly allows us to risk stratify and identify the best intervention for patients. Here though, kind of given in general when it comes to illicit substances, we don't have a ready appreciation of what moderate use looks like, not even for cannabis. So a moment someone has a positive response to any of those questions, the yes, the no's, or they've checked any of those boxes, they automatically are going to fall into the risky category, and they should receive a brief intervention. As you score higher, 3 to 5, you're looking at brief intervention with oftentimes brief treatment. And then 6 and above, this prompts concern for the patient having a substance use disorder and needing referral to treatment. Again, when we look at the evidence supporting the use of DAST in the primary care setting, it's not as robust, and that's easily understandable when we think about how it was developed. It was developed in the addiction treatment setting. It does have, though, good utility insofar as helping us assess the severity of use, and it does clearly indicate when someone's going to need and benefit from referral to addiction treatment services, specifically to get medication-assisted treatment. So a big challenge is, how do we deploy this screening for all of our patients? And remarkably, the American College of Surgeons, as well as the Committee on Trauma, has implemented universal screening at trauma centers. So for example, in Billings, both St. Vincent's and Billings Clinic, because they're both level 2 trauma centers, they're required by the American College of Surgeons to do universal screening for alcohol and drug use. Because of the incredible pressures on their time and limited resources, they've really been prompted to find a way to do this efficiently and to scale. They've leveraged an older screening tool for alcohol use disorder, CAGE. CAGE works differently in that it is only 4 questions. And here again, you're seeing the dichotomous yes, no. Insofar as the response is, it asks, have you, the patient, ever felt the need to cut down on your drinking? Have people ever annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? Have you ever felt the need for an eye opener first thing in the morning, a drink to steady your nerves or get rid of a hangover? Answering yes to 2 or more of those questions is a positive screen and has a remarkably high sensitivity in the 90s and a specificity of around 75%. So not as good of sensitivity as audit, but still fairly robust, above 90% insofar as discerning if somebody is engaged in at-risk drinking and needs more treatment. But how can we do this for all our patients? Still doing the CAGE requires that someone ask them a few questions. Never mind if we're also going to be asking about illicit substance use. Well, sure enough, there is a pre-screening option that has a pretty high sensitivity for alcohol and drug abuse. And that's what we care about most in initial screenings, to the point that if someone answers yes or 1 or more to any of the following questions, are they currently in recovery for alcohol or substance abuse? In the case of men, in the past year, if you had 5 or more drinks in a day, for women, 4 or more, and for illicit substance use, how many times in the past year have you used recreational drugs or misused a prescription medication? Any positive response to any of those questions can then trigger the full screener. And in that way, we're really capturing all the patients in need in the same way we would if we used the standard screeners, but we're doing so in a lot less time. And sure enough, UW Harborview Medical Center used pre-screening in its emergency department, to the point that nearly 2/3 of emergency department visits, other than the trauma patients, were pre-screened by social workers. And all primary care visits there were pre-screened. While the cost savings were a wash in year 1, by year 3, ED recidivism, the frequency with which patients were coming back to the ED, fell. And it got to the point that overall utilization rates across the ED and primary care fell enough to demonstrate significant cost savings for the system. In spite of the cost of having to pay for social workers to do the pre-screening, and if resulting positive, the subsequent screening, even brief interventions, they saw cost savings by deploying this model. It's pretty compelling. When it comes to the brief intervention, what we saw, at least in part modeled in that video, was this process of, and it actually happens at the beginning of that video example, explaining our role, oftentimes in the primary care setting, telling the patient that we're really committed to her or his overall care. And as part of that, we'd like to ask permission to discuss drug and alcohol use based on what they specifically responded on the screening forms. And use that as a chance to ask more about alcohol drug use patterns, insofar as kind of what the typical alcohol or drug use looks like for them in a given week. Listen carefully to their responses, really demonstrating understanding in a non-judgmental way. After raising the subject, we provide feedback. Here we can use the audit or DAST and the way it allows us to risk stratify patients to share with them in a very accessible way the risk zone that their score on that screener puts them in, and what that means to their health, their job, their family, and anything else that they have going on they care about that could be adversely impacted by their alcohol or drug abuse. And then looking to enhance motivation, really trying to get people to acknowledge the pros and the cons about their use, because most people feel ambivalent about their drug or alcohol abuse. Explore the readiness to change, and a nice way to do it, especially on the fly, is leveraging that 0 to 10 point scale that we saw nicely modeled in that video. And if people respond that their readiness to change is greater than a 2, ask them why it's not lower. It's a way to really elicit change language and get a narrative that's meaningful to the patients and that you can connect with. If they do respond, and this on occasion happens, it's not too common that I see it, but if someone says they're essentially totally unmotivated, a 0 to 2 on that 10 point scale, you can explore with them, hey, what would it take? How bad would things have to get insofar as how alcohol and drug abuse are impacting your life for you to think about changing your use? And then close by negotiating a plan, summarizing the conversation, the patient's ambivalence, the pros and cons about their use, the readiness to change, and asking specifically what steps they're willing to take. If they're not ready to plan, you can stop the intervention, offer them educational materials. We do, though, whenever possible, really want to help the patient form a concrete plan to change, and within that, help them identify resources they can leverage, including 12-step in the community, and incorporate this as part of their follow-up plan. For those patients who screen in the high risk but don't yet meet the threshold of alcohol or substance use disorder, brief treatment is indicated. This is a manualized course of advanced motivational enhancement that leverages the cognitive behavioral therapy model, in which it's helping patients address unhealthy cognitions like negative automatic thoughts surrounding their alcohol and substance abuse, and target the maladaptive behaviors that may be driving their alcohol and substance abuse. And in doing so, helps them to adopt a change in their lifestyle by getting them more realistic automatic thoughts that tend to be more positive and more high functioning behaviors that can take them several steps closer to recovery. The last step of SBIRT for those who actually meet the likely alcohol or substance use disorder diagnostic criteria is referral to specialty treatment. to see someone like myself, an addiction psychiatrist. And once a patient presents to care, especially if they're coming from primary care, it is really compelling to have the screening done because it really substantiates the diagnosis and can in many ways expedite the treatment, because the patient and I, or whoever's the addiction specialist, can then really jump into finding out what are the details of use and what the patient's goals are when it comes to treatment. The good news is we do have evidence-based, highly effective treatment for most substance use disorders. For opioid use disorder, we can fully saturate the mu opioid receptor with methadone. It's a full opioid agonist. It does have to be as part of an opioid treatment program, of which there are only a few in Montana. And in general, it's not something that's nearly as accessible as the more common option, Suboxone, whose active ingredient buprenorphine is a partial mu opioid receptor agonist. And to the extent it's partial, it's a lot safer. It does not cause absolute respiratory depression. That's why we can prescribe it in the outpatient setting with less monitoring than methadone. Alternatively, we can also use the opioid receptor blocker, naltrexone, the injectable form, IM naltrexone, Vivitrol, is very effective, essentially equal efficacy to Suboxone for treating opioid use disorder. For alcohol use disorder, naltrexone is by far and away the best treatments when you look at the evidence for helping people cut back and ideally abstain from alcohol. Gabapentin can be leveraged and combined with naltrexone to help people cut back and ideally abstain from alcohol, especially when they're within the first 1 to 3 months of abstinence. Disulfiram, commonly known as antabuse, that can help mainly through the deterrent effect. It interrupts alcohol metabolism, causing a buildup of acetaldehyde, which causes nausea, vomiting. People get really sick. They have to take this medication. And as you can imagine, adherence is an issue. It's not nearly as commonly used as naltrexone or gabapentin for that reason. Finally, acamprosate in the most recent studies here in the US did not outperform placebo. It's a medication I never start patients on. For cannabis use disorder, gabapentin can help, in particular for patients who are motivated and cutting back or staying away from cannabis. Finally, for stimulants, in a recent study from December of 2020, it looks like bupropion and naltrexone are back for treatment of meth. There was an initial study that used oral formulations of both medications combined, the bupropion plus oral naltrexone. That ultimately did not yield compelling results. However, using the IM formulation of naltrexone in combination with bupropion has yielded a meaningful impact on helping people cut back from meth use. We hope to see follow-up studies. Additionally, it looks like there's potential for use of long-acting injectable antipsychotics, and disulfiram can help people cut back from cocaine use. It's worth emphasizing, though, across the board for all substance use disorders, motivational interviewing, like we saw modeled a moment ago in that video, as well as 12-step facilitation, getting people in to AA and NA, that's really the crux of treatment with the highest yield.
Can I interrupt you for a second, Dr. Seitz? We have a quick question or a comment from Alana. And I thought it was kind of good. It goes back to that motivational interviewing change language. And she asks, do you ever recommend having the motivation conversation with the person's spouse or family members who might be contributing to the patient's inability to reduce or quit?
Yeah, so essentially how can we appropriately engage family members, any other agents who are playing a big role in perpetuating, enabling the patient's use? That's what I'm hearing. I think, especially if the patient's on board, getting that family member there in the encounter is invaluable, because Alana, as you're acknowledging, alcohol and substance abuse doesn't happen in a vacuum. And if we really look to help patients shift their behavior and focus on those moments when they're kind of at the cusp of perhaps at least cutting back, if not abstaining from substances, but a family member or friend is offering it or enabling use through access to finances, what have you, involving that family member is invaluable. I don't know of compelling evidence for motivational interviewing per se, that really structured approach we saw modeled in the video. I don't know of evidence supporting the use of that for family members, but certainly if we think about how we can really best support patients, getting that family member or friend in clinic or on the virtual visit is invaluable.
Awesome, thanks. Also, and I'm going to ask Carrie Foster to unmute if she feels brave enough. So you might be one of our first practice tests for this echo clinic. But she asks, there aren't very many treatment centers, especially in Montana, and she's describing a patient with chronic ETOH abuse and who's burned all of his bridges. And so I'd invite Carrie to just say a couple of words about that to maybe add some context, and then Bob can weigh in.
Hello, and thank you. I do have a patient, and actually we're just in the process of dealing with him, and have dealt with him a lot in our particular clinic. Resources are slim and then none, kind of. We have exhausted all possibilities here. He's responsive when you use these interview techniques because there are 2 providers here that have done so, myself included. But then what? Because all of the the inpatient treatment centers that we have explored, he has at one time or another in the last 15 years or so been in and or walked away, left a bad taste, and no one will take him. Family kind of burned bridges, so there's no support system, as well as not a lot of resources.
That's a really challenging scenario. I have encountered it a fair amount. Before joining Frontier full time, I was the director of the addiction treatment clinic at Billings Clinic. We'll acknowledge that one of the compelling things about this approach that SBIRT really allows us to pursue in kind of a staged way. It sounds like you're doing the brief intervention, so you're really priming the patient's willingness to change. You're helping getting him to a place where he can start doing things for himself that are going to make a really compelling difference and increase his chance of recovery. You're posed with the challenge of, okay, what can I do in overcoming this logistical hurdle of actually getting the patient access to medication-assisted treatment? It sounds like never mind residential rehab. That's not a compelling option given the patient's history of essentially leaving that. The nice thing about MAT, in particular the naltrexone and gabapentin, it's generally safe, and it's something that can be pursued in the outpatient setting. I know, for example, in Billings, Riverstone does offer that form of MAT in their primary care.
Mm-hmm.
So it may just be a matter of trying to find a physician, nurse practitioner, or PA who's relatively facile with the MAT and getting the patient access to medical care in that way. The more we can do to prompt the patient to seek sober supports, that's going to be incredibly meaningful. And oftentimes, Alcoholics Anonymous is incredibly powerful in that it gives people a sense of community and allows them to relate to other people who have that concern of how do they stay away from alcohol and really channel their energy into clean and sober living. Now, AA is not a great fit for everyone. And I'll say, I'll take whatever I can get insofar as people seeking out a support, be it a group setting or otherwise. For better or worse, here in Montana, I don't know of other 12-step groups beyond Alcoholics Anonymous. Where I trained in Seattle, there were other options. I don't know of that here. I don't see that there's like rational recovery, anything like that here in Montana. So I really do whatever I can to encourage folks to make their way to an AA meeting.
I will also note that at least in Montana, the Montana Peer Support Services, their website offers free virtual little podcasts and whatnot that people can listen to that might also keep that motivation going to power through some of those cravings and different things like that happen. I also did want to bring up a question that Alana had mentioned in, well, actually 2 questions. One was on specifically regarding the medication-assisted treatments for alcohol use disorder. How long are patients on those drugs? Can they stay on them for a lifetime, or is there a tapering process? And then secondly, the second question would be specific resources for cultural groups, specifically the American Indian, Alaskan Native, but we also have a lot of Hawaiians on our particular call today. So some of that cultural resonance that might be more effective for some patient groups.
Yeah, so I'd say yes to all of the above when it comes to those questions. It does get nuanced. We are going to do an entire echo clinic on medication-assisted treatment of alcohol use disorder. I think that's coming up in keep me honest here, Amber, if I'm not mistaken, six weeks or so, maybe longer. But it's on the curriculum. Stay tuned, and we'll be doing that in short order. So in thinking about the role for medication-assisted treatment, we really want to see what is the patient's relationship with alcohol. How are they using it? Sure enough, the majority of people who have an episode of alcohol dependence are able to recover without significant intervention. Now, a lot of those people never really make it to our clinics because sure enough, they self-select as not needing treatment. Makes sense. So a lot of those people we never hear from. Chances are, if we're seeing a patient in our clinics who seems positive or self-presents requesting help with alcohol abuse and or has really bad outcomes insofar as liver function and other untoward effects on their physical health, at that point, that person is really self-declaring as somebody who needs some sort of treatment. I very much focus patient-centric practice in which I work with patients to get their sense of meaning. Increasingly, we know that abstinence is not just the absence of alcohol or drugs. It's pursuing meaning, spending one's time, one's resources in a very different way than they've been doing. So finding a way to really support them and engage them in that pursuit. The medication-assisted treatment can be invaluable, in particular for people who recurrently are unable to cut back and ideally abstain from using alcohol on their own. And we'll talk about in detail how specifically naltrexone blocks mu-opioid receptors, and in doing so stops endogenous activation of those receptors that we see with alcohol. And by doing that, you basically break the reinforcement. You also decrease the level of cravings. And remarkably, we saw from a study done at UW Harborview in 2015, you can even use long-acting injectable naltrexone to help patients who aren't treatment seeking cut back the amount of alcohol they consume. They saw that in a cohort of alcoholic, chronically homeless men who were coming into the ED, that they were able to enroll in treatment. Treatment just being the injection, but they continued to drank less, and were able to cut back. That's simply to say there are multiple different ways to pursue this, and part of what's going to inform how and what you do is what the goals are. I do oftentimes, at least for alcohol and a few other substances, practice a harm reduction approach, and will continue to treat people, even if they continue to use, because there's so much at stake. And I don't think it's ultimately fair to their overall health to insist on abstinence, and the evidence favors harm reduction. When it comes to culturally competent resources, I can't say I have intimate knowledge of what's available, for example, in Hawaii, but pulling from that really universal acknowledgement, and it's been validated across different patient populations, subpopulations, that helping people find meaning above, outside, and beyond alcohol and substances is incredibly powerful. To that extent, be it someone's faith, their family, their immediate community, helping them channel their energy toward that and get them more socially connected is going to be incredibly protected. I do know Alcoholics Anonymous, having gone to medical school in San Francisco and attended Alcoholics Anonymous as part of my curriculum, and then later attended it in training in Seattle, remarkably different insofar as the extent to which the group was fairly diverse, what was emphasized. I would encourage folks when it comes to AA or NA or any form of 12-step to be really informed consumers and be willing to try several different groups because they can vary widely. I know we're running a little short on time, just got 5 minutes left, and there's some more questions. Great, awesome. Cases, podcasts, excellent. Yeah, May 5th, look at that, right around the corner.
We actually have a case for the May 5th already submitted. So, but you know, all of these cases that get submitted, they don't have to match exactly because this content is going to become kind of a circular event, and we're going to be revisiting those concepts over and over again. So if you have a particular case that you are struggling with, or even if you have a success story to share or a problem, feel free to speak up. I'll put my contact name in the chat, and you can just correspond with me, and we can figure out the best way to get your issue resolved, or at least help. And we want your feedback, so fill out your evaluation forms. Last thought. Do you want to, Julie just asks, did you say instead of total abstinence for alcohol, low use and meaningful? Do you want to kind of recap that? I liked that language that you used about something about finding things that were meaningful in your life. I put joy.
Well, yeah, I mean, some of this is going to be, and Julie, please feel free to chime in if this doesn't acknowledge what you're getting toward. So some of this has to do with kind of how we know people make decisions. So often it's a lot easier to stay away or reduce the influence of something in one's life by substituting with something else. We are human beings and also human doers. And so social connection, also having healthy activities that get us in places where alcohol is not front and center stage, which can be challenging. We live in an alcoholic society. Let there be no mistake about it. It is highlighted in the vast majority of social events that many of us show up for. So helping people find alternatives and good, meaningful connections to people that don't involve alcohol is incredibly powerful. When it comes to choosing total abstinence versus use reduction, what I share with patients is that all the evidence we have, if someone does truly have alcohol use disorder, is total abstinence works a lot better. And that the medication, if we choose to go that route, is going to be way more effective. That said, fortunately, at least when it comes to alcohol, we do have meaningful treatment to help people cut back. And if that's all that is feasible, we'll take it because it's way better than the alternative.
Awesome. And Alana mentions that she definitely agrees that being part of the resiliency for the American Indian, Alaska Native is being connected to the culture and helping to bridge the generations that renew that pride in the culture. So
Excellent.
awesome. Well, keep your questions coming, keep your feedback coming. That makes it better for all of us. So any last, you got 1 minute. Going once, going twice. Thank you all so much for attending, and thanks for being willing to be on camera as well as be on mic too. So thank you very much, and we'll see you in 2 weeks.
Thanks, everyone.